So today we will be discussing about two of the cardiology topics. One is the heart-lung interaction and second one is the cardiac output monitoring. So if time permits, we'll cover the infective endocarditis also because it's hardly 10 to 12 sites. It's a small topic because tomorrow Dr. Sanantha's class will be a bit longer. So we'll try to finish it today, if not tomorrow. And I will also give a recorded class on fluid responsiveness because of the time limits we could not cover that also. So fluid responsiveness will be given to you as a recorded class. You can listen in the recorded sessions. Okay. So we'll wait for 1 or 2 minutes and then we'll start. Any doubts you can put in the chat box or in the WhatsApp group. We will get back to you. So the first topic we are going to discuss is about the heart-lung interaction. So we'll be seeing the definition and how the heart-lung interaction happens during a spontaneous breathing and during a mechanical ventilation. Okay. So what is the definition of an heart-lung interaction? It is the physiological relationship between the cardiovascular and the respiratory system because both the systems are in a confined space called thorax. So one system is going to get influenced by the pressure dynamics of the other system. Okay. So this is the definition of the heart-lung interaction. You can see here, the thorax is a shared cavity between the large respiratory pump and a small circulatory pump. Okay. So these pumps operate within a confined space called a thoracic space. And whenever there is a change in the pressure dynamics of one system, it is going to affect the other system definitely. So here, the respiratory system will act as a suction pump. So whenever during a spontaneously breathing patient, whenever they take an inspiratory effort, there is going to be a generation of negative intrathoracic pressure, right? This allows the airflow into the lungs by creating a pressure gradient for air entry. That is the reason it acts as a suction pump by creating a negative intrathoracic pressure during inspiration. Whereas the circulatory pump acts as a pressure pump where it generates positive pressure to propel blood into the arterial system. So basically from the arterial system, it goes into the systemic circulation. So you can see that how contradictory these two systems function and how one system can influence the other by the pressure dynamics, right? So this negative intrathoracic pressure during inspiration can change the venous return to the heart because of the external pressure on the cardiac chambers and the large veins and the arterial system. Okay. In normal people, in normal physiological conditions where the patient's cardiac function is good, the lung compliance is good, where the patient is not mechanically ventilated, this heart-lung interaction is going to be very minimal, where it may not change major venous return or it may not change anything much with the cardiac system. But in a mechanically ventilated patient or in a patient with acute asthma or COPD, where there could be dynamic hyperinflation, where the alveoli is damaged and may not able to take up the PEEP, or in cases of acute left heart failure where the heart compliance is very bad, where it could not accommodate the venous return or changes of the heart-lung interaction. And even in patients who are weaning off from the mechanical ventilator, there will be opposite effects which could be seen with the mechanical ventilator, where these heart-lung interactions could be more prominent. So let us see the heart-lung interaction in a spontaneously breathing patient. What happens to the right side of the heart as well as the lung. Okay. So in a spontaneously breathing patient, during inspiration, what happens? The diaphragm contracts and lowers. Okay. In the thoracic cavity, there is negative intrathoracic pressure and the alveolar pressure becomes less than the atmospheric pressure, where the air flow into the airways. Okay. So during spontaneous inspiration, there is negative intrathoracic pressure and the alveolar pressure becomes less than the atmospheric pressure and the air flow into the lungs. But at the same time, the diaphragm also contracts, right? It lowers. It exerts a pressure on the abdominal cavity, where the intra-abdominal pressure becomes more. So this pushes the some of the blood flow to the venous return, which may increase the venous return, which we'll be seeing in the next slides. So when it comes to the lung, during spontaneous inspiration, there is negative intrathoracic pressure and the air enters into the lung. Okay. What happens to the cardiac side when a patient is spontaneously breathing, that too on an inspiratory phase? So we saw that during inspiration, there is negative intrathoracic pressure. So the systemic venous return to the right atrium is usually driven by the pressure gradient between the upstream capacitive venous system, where the mean systemic pressure prevails, and the downstream right atrium. So the systemic venous return is closely related to the right atrial pressure. If the right atrial pressure decreases, the venous return increases. Okay. Whenever there is a negative intrathoracic pressure, because the heart is also inside the thorax, the right atrial pressure also comes down. And at the same time, we saw there is increase in the intra-abdominal pressure because of the diaphragmatic descent. So this in turn pushes the unstressed volume to the stressed volume and increases the venous return. So overall, there is increase in the pressure gradient, increase in the venous return, and there is increase in the right ventricular preload. From the right atrium to the right ventricle, there is increase in the right ventricular preload. So during inspiration, in the thorax, there is negative intrathoracic pressure. So air enters the lung, but at the same time, the right atrial pressure also comes down and the venous return increases. Overall, in the right side of the heart, there is increase in the right-sided preload. Coming on to the right ventricular afterload. So we have seen about the lung, we have seen about the right-sided preload. Now we are going to see about the afterload in a spontaneously breathing patient during inspiration. So we know that the lung has, the alveoli has two types of vessels. One is the intra-alveolar vessels, one is the extra-alveolar vessels. During inspiration, we know that the lung volume is going to increase. The alveoli is going to distend, right? So whichever vessels which are intra-alveolar is going to get compressed. So the intra-alveolar vessel resistance is going to increase exponentially. But the extra-alveolar vessels, because of the radial interstitial forces and outward traction of the vessel walls, there is going to be drop in resistance in the extra-alveolar vessels. So overall, whenever the alveoli expands, there is increase in the intra-alveolar vessel resistance because of the compression of those vessels because of the distending alveoli, and there is a decrease in the extra-alveolar vessel resistance because of the radial interstitial forces. So overall, there is going to be net increase in the total pulmonary vascular resistance. When the pulmonary vascular resistance increases, the right ventricular afterload also increases. So you can see that the total pulmonary vascular resistance follows a U-shaped curve, where the nadir is seen at the lung volume equal to the functional residual capacity. Whenever the lung expands, the intra-alveolar vessel resistance is going to expand and the extra-alveolar resistance is going to reduce. And not only that, the pulmonary circulation is distributed along the gravitational gradient. We know that there is West Zone 1, 2, and 3, and there is also West Zone 4 based on the gravitational gradient, where one pressure is higher than the other pressure in 3 different zones, right? During spontaneous inspiration, because there is decreasing intrathoracic pressure more than the alveolar pressure, it may cause a large proportion of the pulmonary circulation to behave as in West Zone 2. Okay, so overall, there is increase in the pulmonary vascular resistance and increase in the right ventricular afterload. But in normal conditions where the compliance of the lung is good, where the efforts are normal, this resistance increase is very minimal and may not impact the cardiac function, neither the lung function. So we have seen the changes with respect to thorax, the right ventricular preload, and the right ventricular afterload. Now let us go to the left side of the heart. What happens to the left ventricular preload? So during inspiration, we know that there is a negative intrathoracic pressure. There is increase in the right ventricular preload and also right ventricular afterload. So overall, the right side of the ventricle has a higher volume and a stroke volume. When you see that thorax as a box, there is and pericardium as a smaller box where the right and left side of the ventricles are accommodated, you can see that there will be 2 types of interdependences with right to left side of the heart. One is the serial ventricular interdependence. This is the the transmission of these changes in the preload to the left side of the heart from inspiration to expiration which usually takes time, like 2 to 3 cardiac cycles it takes from inspiration to expiration. That is called serial ventricular dependence. This increase in the right ventricular stroke volume to get transmitted to the left ventricle and to increase the left ventricular volume, it takes a longer time, which is called pulmonary transit time. So whatever effect which is seen in the right side of the heart, that effect will be reflected on the left side of the heart only during expiration because of the pulmonary transit time. It has to cross through the pulmonary circulation, it has to go to the left side of the heart. So it takes time to see those effects on the left side of the heart, and that usually happens with expiration. So whenever there is increase in the right ventricular volume because of the serial ventricular interdependence, these changes will be seen on the left side of the heart only during expiration. But during inspiration, the LV filling is going to get reduced only. Okay. And there is also parallel ventricular interdependence because the right side of the heart is distended with increased volume. This can compress the left side of the heart, which can again reduce the left ventricular filling. So overall, during inspiration in a spontaneously breathing patient, the left ventricular preload is going to go down and it is going to increase only during expiration. One, because of the serial ventricular interdependence, and number two, because of the parallel ventricular interdependence. Coming on to the left ventricular afterload. The left ventricular afterload can be defined as the effort required by the left ventricle to eject the blood up to the level of the pressure of the extrathoracic vessels. So during inspiration, there is a negative intrathoracic pressure, which places the left ventricle at a lower level at a negative pressure and makes it ejecting effort greater, thus increasing the left ventricular afterload. So overall, there is increase in the left ventricular afterload. And not only this mechanism, there is also a mechanism called transmural pressure. Okay, during inspiration, whenever there is negative intrathoracic pressure, the aortic root, which is located in the thorax, is again subjected to the negative intrathoracic pressure. But the extrathoracic vessels, such as abdominal aorta, which are exposed to the atmospheric pressure, will remain higher compared to the intrathoracic aorta. So this will create a pressure gradient where the intrathoracic segment of the aorta experiences a relatively pressure reduction compared to the extrathoracic segments. So overall, the transmural pressure is going to get increased. So whenever there is an increase in the transmural pressure, the left ventricle has to eject against this increase in the transmural pressure, leading to increase in the left ventricular afterload. So overall, what happens? During spontaneously breathing inspiration, there is negative intrathoracic pressure. The air flows inside the lungs, and in the right side of the heart, there is increase in the preload because of the negative intrathoracic pressure. There is increase in the venous return. There is increase in the right-sided preload, right ventricular preload. But because the alveoli is distending and there is intra-alveolar resistance, the right ventricle is going to have increased afterload. And because of the interdependence, the left ventricle is going to see all these effects only during expiration rather than inspiration. So the left ventricular preload is going to go down. And because of the increase in the transmural pressure, the left ventricular afterload is going to increase. So this is the summary in a patient who is spontaneously breathing during inspiration. And the same opposite effects happen in the expiration. Okay. So if there is any doubt, please put it in the chat box. I know it is exhaustive because to understand the transmural pressure newly or to understand the pulmonary vascular resistance newly, it may be a bit difficult. But if you read through the slides with the reference articles which we'll be sharing, it will be easier for you. Okay. So now what happens during mechanically ventilated patient? If any of the participant is willing to attempt, then I'll be happy. Like, can any one of you try? Like, what happens during mechanical ventilation? Or at least can any one of you tell what happens during spontaneous ventilation? Inspiration, expiration? Okay, no issues. So we'll just conclude with the spontaneous alone so that when we are going to the mechanically ventilated patients, you can see there will be some differences. So in a spontaneously breathing patient, during inspiration, the intrathoracic pressure goes down, the venous return increases, the right ventricular preload increases, but because of the distension of the alveoli, there is increase in the intra-alveolar vessel resistance and the right ventricular afterload increases. But because of the interdependencies, this effect is going to take time to reflect on the left ventricle. So the left ventricular preload is going to go down. And because of the increase in the transmural pressure, the left ventricular afterload is going to increase. This is the overall gist of the heart-lung interaction in a spontaneously breathing patient during inspiration. Now, what happens during a mechanical ventilation? We know that mechanical ventilation is nothing but giving a positive pressure to the alveoli, right? So overall, the intrathoracic pressure is going to increase. It is going to become a positive intrathoracic pressure in contrast to the spontaneously breathing. Right. So whenever you initiate a mechanical ventilation by giving a positive pressure, the intrathoracic pressure is going to increase, which in turn is going to reduce the venous return, which is going to reach the right side of the heart. So overall, the right ventricular preload is going to go down, right? At the same time, if, for example, in a patient with a good lung compliance, or we are not giving any major PEEP, or if the patient's cardiac function is good and the volumes, I mean, the vascular volumes, intravascular volumes are good, this is usually counteracted by the other pressures, like the intra-abdominal pressure. We know that during mechanical ventilation, we are giving a positive pressure. So there is going to be increase in the intra-abdominal pressure also because of the descent of the diaphragm. And the redistribution of the blood happens from the unstressed volume to the stressed volume. At the same time, when you're giving a mechanical insufflation, it activates the baroreceptors, which in turn is going to activate the sympathetic system, where further it increases the mean systemic pressure. So overall, in a mechanically ventilated patient, when things are okay, when the lung compliance is okay, when you're giving an optimal PEEP, when the cardiac function is all right, then the other pressures, the counteracting pressures and the sympathetic system will try to match the reduced venous return and try to increase the venous return. That is why we don't see this gross changes in all patients who are mechanically ventilated, because the body's own mechanism, the other pressures, the baroreceptor mediated mechanisms will try to keep up the venous return in a mechanically ventilated patient. You should just know, whenever you're giving a positive pressure ventilation, the intrathoracic pressure becomes positive, the venous return decreases. But in normal patients, this venous return reduction is counteracted by some of the forces and the baroreceptor mechanism, so that no major gross changes happens in most of the patients. Okay. What happens with the RV afterload? We saw that in a spontaneously breathing patient, in the alveoli distance, there is going to be changes with the resistance in the intraalveolar and the extraalveolar vessels. The same thing will be seen in a mechanically ventilated patient also, because here also we are distending the alveoli. The intraalveolar vessel resistance is going to increase. The extraalveolar vessel resistance is going to decrease. So overall, there is increase in the pulmonary vascular resistance, and most of the zones are going to behave like a West zone 2, and there is going to be increase in the right ventricular afterload. The same thing is going to be happening in a mechanically ventilated patient also, and in a spontaneously breathing patient also. Okay. Coming on to the left ventricular preload. So here there are some changes when it comes to spontaneously breathing patient and a mechanically ventilated patient. Okay. So initially, when you give a sudden positive pressure, the pulmonary vessels will try to squeeze some of the blood which it has as a reservoir into the left ventricle, so that there could be a transient increase in the left ventricular preload. Okay, it is mainly because of the increase in the transpulmonary pressure when you're giving a positive pressure ventilation, so which shifts the pulmonary venous blood into the left atrium, leading to left ventricular filling and preload. The second effect which we are going to see with the left ventricular preload is that same interdependencies. Like you can see that in a serial ventricular interdependence, during insufflation, there will be decrease in the venous return and decrease in the right ventricular preload. So for this effect to act on the left ventricle, it is going to take some time, which is usually reflected during expiration only. So the venous return reduction in the right ventricular preload to be reflected in the left ventricular preload, it is going to take some time. That is going to be seen in the expiration. At the same time, the parallel ventricular interdependence, like the right ventricle and the left ventricle, it is not going to hamper the left ventricular filling because the right ventricle itself is less filled because of the decreased venous return. So overall, during mechanical insufflation, like inspiration, there is going to be increase in the left ventricular preload because of the squeezing, and during expiration, there is going to be decrease in the left ventricular preload. Okay. So what happens during expiration? We saw that there is a transmural pressure of the aorta, which is going to reduce in cases of mechanical ventilation because the intrathoracic aorta is going to be at higher pressure levels. The extrathoracic vessels is going to be at lower pressure levels. There is going to be reduction in the transmural aortic pressure. So this will in turn makes the left ventricle to the left ventricle need not eject the blood at a greater force because the transmural pressure is low. So it is going to eject the blood very easily because of the reduced transmural pressure. So the left ventricular afterload is going to go down. Okay. So if you see in this picture, during mechanical ventilation, you can see there is reduction in the RV preload because of the positive transthoracic pressure, intrathoracic pressure, and there is small increase in the right ventricular afterload because of the increased intraalveolar vessel resistance. That is with respect to the right ventricle. When you see the left ventricle, there is going to be increase in the left ventricular preload because of the squeezing of the reservoir pulmonary blood because of the increased transpulmonary pressure, and because of the serial as well as parallel interventricular dependence. And at the same time, there is going to be decrease in the left ventricular afterload because of the reduced transmural pressure. But when you see the spontaneously breathing patient, there is going to be increase in the RV preload because of the negative intrathoracic pressure. There is going to be similarly a small increase in the right ventricular afterload, but the left ventricular preload is going to go down because of the serial and the parallel ventricular dependence, and the left ventricular afterload is going to go high because of the increased transmural pressure. Okay. So this is the overall gist of heart-lung interaction. So this finishes our heart-lung interaction. We'll be going to the next topic, that is cardiac output monitoring. Yeah, Priya, you had messaged mechanical ventilation is positive pressure. Okay, so you were trying to explain the concept. Okay. So we'll be moving on to the second topic, that is cardiac output monitoring. It is going to be an extensive topic. I'll try to explain as much as possible so that you can understand the concepts alone. In the recent exam papers, they had asked about write about invasive cardiac output monitoring devices alone, write about non-invasive cardiac output monitoring devices. So all you have to know is the basic concepts, how they function and how they evaluate the cardiac output and what are the limitations mainly. Okay. So we'll be moving on to the cardiac output monitoring. Can any of the students say when do we usually do cardiac output monitoring? Because in the centers where I practiced also, there was not a routine method of monitoring cardiac output because of the availability, the cost factors, and even when I was trying to get evidences for the classes, there were not much studies which are validated for most of the cardiac output monitoring devices, mainly because of the availability as well as the budget, which where it requires a lot of transducers, and every day you have to change the transducer, calibrate the transducer. Is like a big work. So can any one of you tell me what are the major indications of cardiac output monitoring? We have clinical factors, we have ABG, we have NIBP, we have intra-arterial monitoring. What is the major difference? Why do we need cardiac output monitoring basically? Can any one of you try? Okay, so basically, when a patient has a multifactorial shock, for example, a patient is presenting with septic shock, he may have a septic cardiomyopathy, which we may not be even with a poor cardiac function, we may not know how to titrate the fluids, inotropes, vasopressors. We just see the basic POCUS bedside ultrasound, and then we try to see whether the patient is fluid responsive or not, and then we try to adjust. But when you have a real-time cardiac output monitoring, you can see that with a depressed cardiac function and in a multifactorial state, like a septic shock or a hypovolemic shock, whether the depressed cardiac function, whenever you are resuscitating, is worsening or it is remaining the same. In order to resuscitate in a patient with a multifactorial shock state, then cardiac output monitoring would be a great tool, so that we can see the real-time changes in the variations, the vascular resistances, and the cardiac output, which may be helpful. Okay. And in cases where we are doing high risk cardiac surgeries like valvular surgeries or aortic surgeries or the major cardiac surgeries, it may be useful. And in abdominal surgeries also, like HIPEC surgeries, where they lose a large amount of fluid as well as blood during the procedure. And even if they have a depressed cardiac function, how to monitor such patients and how to resuscitate such patients, cardiac output monitoring could be useful. And whenever you receive a patient in an ICU with a depressed cardiac function, then you can have a protocolized approach for individual patients, like not like a strict rule 30 ml per kg. I'm going to give 20 ml per kg, which may even cause fluid tolerance, organ dysfunction, where you can individually create a protocolized version of treatment for each patient. When you have a cardiac output monitoring device, it becomes easier based on their vascular resistances, their output, their index. Based on that, the age, nomogram, everything matters here. Everything will be applied in a cardiac output monitoring. So it may be easy in a multifactorial situations or in patients who are undergoing high risk surgeries where they have a depressed cardiac function, or in order to individually protocolize a fluid therapy or a vasopressor therapy in ICU patients, cardiac output monitoring could be a great tool. Okay. So how are we gonna classify the cardiac output monitoring devices? One is based on the principles. One is based on the invasiveness. Okay. Based on the principles, there are only 4 major principles using which the cardiac output monitoring devices function. Number one is the fixed principle. I hope we have been reading this fixed principle from physiology times, right? Which is defined as the total uptake or release of any substance by the lungs is the product of blood flow through the lungs and the arteriovenous substance content difference, right? So the fixed principle was initially invented with the oxygen, where they found out cardiac output using the oxygen derived parameters and applying it in a formula where they derived the cardiac output. That is the very old fixed principle, where nowadays we don't use that at all. Okay, but the variation of the fixed principle has been formulated into various algorithms, has been modulated into various algorithms like Stewart-Hamilton algorithms and even uncalibrated devices based on age nomograms. It has been converted into various algorithms where the recent cardiac output monitoring devices use the modified fixed principles. Actually, this forms the basis of the cardiac output monitoring devices, most of the devices. Okay, for example, if you see thermodilution techniques or dye dilution techniques, these are all some of the techniques which uses the modified fixed principle. Okay, the second technique which is commonly used for cardiac output monitoring is that arterial waveform analysis techniques, okay, which we'll be discussing later. And the third technique is that transthoracic impedance and bioreactance, which is one of the non-invasive, uncalibrated version of cardiac output monitoring, which we'll also be discussing. And the fourth principle is the Doppler principle, which has been there for so many years since 1990, like where you use left ventricular outflow tract diameter and velocity time integral, and you just apply it in the stroke volume formula and you get the cardiac output. So there are 4 major principles using which the cardiac output monitoring devices function. Number one is the fixed principle and the variation of the fixed principle. Number 2 is the arterial waveform analysis. Number 3 is the transthoracic impedance and bioreactance. And number 4 is the Doppler principle. So if you want to classify cardiac output based on the principle, this is how you have to classify. And if it is asked as a question, then you have to start writing what are all the arterial waveform analysis techniques, explain about impedance and bioreactance and the Doppler principle also. But this method of classifying, meaning the invasive and the non-invasive, calibrated, non-calibrated version, is a bit easier. Okay. So when you, depending on the invasiveness, when you classify cardiac output devices, it can be classified into invasive, which is mostly the pulmonary artery catheter, wherein you have to pass in the catheter through the central venous line and see the thermistor changes. And then using the area under the curve, you are going to find out the cardiac output, where the pulmonary artery catheter can detect the cardiac output intermittently or continuously. So this is one version. Then coming on to the minimally invasive devices. Most of the minimally invasive devices either use pulse wave analysis as the technique or Doppler as the technique. Doppler means it is transesophageal echo. But pulse wave analysis has various versions because of the calibration, which we'll be discussing, and then we'll come back to this slide again. And then non-invasive methods are where we don't prick the patient only, we just connect electrodes outside, or we just ask the patient to rebreathe carbon dioxide, or you put a thoracic echo and find out this. These are the some of the non-invasive methods. So based on the invasiveness, it can be divided into invasive pulmonary artery catheter, minimally invasive pulse wave analysis and Doppler esophageal echocardiography, and the non-invasive, which is partial gas rebreathing, bioimpedance, bioreactance, Doppler transthoracic echo, and using the endotracheal tube, there could be a cardiac output monitor. Okay. Before going into the topic proper, like about the cardiac output devices, we will see what are calibrated devices, what are non-calibrated devices. So can one of you tell me, in your ICUs, every day there is an ABG machine which processes like hundreds and thousands of samples, and every day there is a procedure called calibration. Can one of you tell me why the calibration is being done? Like, what is the necessity of the calibration for those monitoring devices? Can any one of you tell me? You can put it in the chat box also. Okay. So basically, this calibration is done whenever you're monitoring a patient continuously. I'm talking with respect to cardiac output monitoring devices. When you're monitoring a patient continuously, okay, the system has to remain accurate. Okay, it should not keep changing grossly because of the environmental disturbances, like the the transducer problems, or the pressure transducer problems, or the line problems, or because of that externally, or internally because of the patient's physiological condition. Suddenly the patient is having hypotension, or there is a movement, or there is a sudden arrhythmia, or there is a sudden cardiac dysfunction. Because of these reasons, because of these physiological and the pathological conditions, there should not be any gross variations, right? You should have a standard value where you can compare the cardiac output cardiac output monitoring is happening or not properly. And at the same time, when you do repeatedly, the samples are matching with the baseline value or not, and how far it is different from the baseline value. That much you have to know, and you should have a standard value. To get that standard value, you have to calibrate the device, especially every 8th hourly, or whenever there is an arrhythmia, or whenever the vasopressor requirement is changing, or whenever the patient is having gross hemodynamic fluctuations. You have to calibrate the device, and you should have a baseline value, so that whenever you're continuously measuring the cardiac output monitoring, you can compare it with the baseline value, even for evaluation, and even to predict, oh, there is a gross difference, maybe it's not right. You should calibrate and get back and see how it is compared with the baseline value. So this process is called calibration. So in a scientific definition, you can tell it is basically performed to eliminate or reduce bias when you're measuring a value for a long time, or in a state of continuous monitoring. Okay. So first, it is going to see whether the monitoring device is precise. And second, it is going to see the monitoring device is accurate or not. What is precision? When you repeatedly check the value, whether it is showing the same result or not. What is accuracy? Whether it is at least close to the baseline standard value or not. So in order to do that, you have to calibrate the device at periodic time intervals, as mentioned by the cardiac output monitoring device manufacturers. And at the same time, whenever the patient is having gross disturbances in the hemodynamic status. Okay. And this calibration can happen externally. For example, we saw some of the devices like thermodilution techniques, dye dilution techniques. These are all some of the calibrating methods where we use external calibration, where you have to inject a cold saline and get an average value to get a cardiac output baseline value. And these are called externally calibrated devices. There are internally calibrated devices like flow track, Litco Rapid. These are all some of the devices which calibrate themselves without any cold saline or dye dilution techniques based on the patient's age, hemodynamic status, nomograms. It just adjusts automatically. So this process is called internal calibration or non-calibration. Okay, a non-calibrated technique, it tries to reduce this bias by implementing correction factors. These are pre-programmed correction factors that has been formulated by the device producers, the manufacturers, and this is mainly based on the nomogram scaling factor based on the patient's demographics, or an equation correction factor based on measurement characteristics. So this process is called internal calibration or an uncalibration. Okay. So calibration, it's mainly done to maintain the precision and the accuracy of the monitoring devices. It can be done externally in cases of thermodilution and transpulmonary thermodilution or dye dilution techniques, but it can be internally done with some of the newer devices, more non-invasive devices like flow track and Litco Rapid. So now if you go back to the chart, you can see that in minimally invasive techniques, we are following pulse wave analysis or a Doppler esophageal echocardiography. In pulse wave analysis, the to be calibrated devices are Pico Plus, Litco Plus, and Volume View, which uses transpulmonary thermodilution with pulse wave analysis. Okay. The uncalibrated version or the internal calibrated version, which uses pulse wave analysis, are Flow Track and Litco Rapid. Okay. Now going on to the actual cardiac output monitoring devices. The first one we saw was invasive cardiac output monitoring device, that is the pulmonary artery catheter, which can be inserted via IJV, subclavian vein, and rarely via femoral vein. We know that pulmonary artery catheter is also called a Swan-Ganz catheter, which is 60 to 110 centimeter in length. And there are pediatric versions and there are adult versions also. It is made from polyvinyl chloride that is pliable at the room temperature and softens at the body temperature. And it is marked at 10 centimeter intervals. So this pulmonary artery catheter, it's not only used for cardiac output monitoring, but it is also useful for temperature monitoring, as well as to see the right-sided pressures, the pulmonary artery pressures, and to get the mixed venous saturations. And also when the with the wedge pressure, you can see the left-sided cardiac function. Okay. So what are the parameters we are going to get from the pulmonary artery catheter? Mixed venous oxygen saturation and some of the oxygen delivery, uptake, and extraction ratios. And the derived parameters will be SVR, PVR, cardiac index, stroke volume index, and the left ventricular stroke work and the right ventricular stroke work. I don't think reading the formula or telling you the values, which you may not be able to remember all of it. You can just take a screenshot during your recorded versions and just read through it. Even in exams, you need not write in detail about the formulas or the values. Okay, you should know what you can derive from the pulmonary artery catheter. And coming on to the parts of the pulmonary artery catheter, you can see that there is a distal yellow port, which is mainly used for the pulmonary artery pressure monitoring and also sampling for the mixed venous oxygen saturation. And the second port is the blue port, where it is mainly used for central venous pressure monitoring. And you're going to inject the cold thermodilution saline through this only for the cardiac output monitoring also. And the third lumen is the red lumen, which is mainly used for balloon inflation. And the fourth lumen is mainly for thermistors, where it is attached to a thermistor and it senses the cold saline changes with respect to the cardiac output and the blood flow in the pulmonary circulation. And the fifth port can also be there optional, where it can be used for right ventricular infusions as well as pacing. Okay. So as per the, during insertion of the pulmonary artery catheter, as per the location of the guiding balloon, the waveforms also changes. With respect to right heart, there may be ACB waves. When it reaches the right ventricle, there may be a systolic wave, but close to zero diastolic wave. But once it reaches the pulmonary circulation, there can be a definite systolic and a diastolic wave. And once it is wedged, again, it becomes the same as this as A and V wave. Okay. And the normal value of pulmonary capillary wedge pressure is 8 to 12 millimeter mercury. And ideally, it should be at the zone 3 of the west zone, where the pulmonary arterial pressure is more than the venous pressure, which is more than the alveolar pressure. And in an X-ray, you can see that the level of it should be at the level of left atrium within 2 centimeter of the cardiac silhouette. And when you draw the blood, the oxygen saturation will be similar to that of the arterial blood gas saturation. Now, coming on to the cardiac output. So we saw what is pulmonary artery catheter. How it is going to detect the cardiac output is what we are going to see now. So you are going to inject a cold saline through the port which I showed you before. You are going to inject the cold saline in the proximal part of the pulmonary artery catheter, and the thermal variations of the blood are measured using the thermistors which are in the other ports of the pulmonary artery catheter. Okay. So the cardiac output and other derived indices which we discussed before is going to get derived from a modified version of the fixed principle that is called Stewart-Hamilton equation. So this is the Stewart-Hamilton equation, where it detects the cardiac output by the changes in the by the thermal changes in the blood flow across the pulmonary circulation by using the modified Stewart-Hamilton equation. So the area under the curve is usually the one which is the factor which is used to derive the cardiac output. And usually the area under the curve is inversely proportional to the flow rate in the pulmonary artery. You can see here, whenever the cardiac output is high, the area under the curve narrows. Whenever the cardiac output is low, the area under the curve increases. So it is inversely proportional to the blood flow, which in turn derives the cardiac output using the equations. So when you're injecting the cold saline, 3 such average readings are taken. And then finally, a cardiac output value is being reflected in the monitor. Okay. But there are many factors which could affect the cardiac output monitoring. For example, we presume that whenever we put a pulmonary artery catheter, we presume and assume that the valves are normal, there is no shunt, and it is going to detect the pressure with the volume, all that. But there could be a lot of limitations whenever there is intracardiac shunt, or whenever any valvular problems like tricuspid regurgitation, stenosis we won't insert only if there is a regurgitation or a pulmonary regurgitation, or there is a gross respiratory cycle variations with respect to heart-lung interactions, like the lung is very bad, you're putting on higher PEEP, and then this is in turn affecting the cardiac output. So all these factors could be limitations for the pulmonary artery catheter. And we saw that pulmonary artery catheter can intermittently calibrate the system by the cold saline, and then it measures the cardiac output, and it can also continuously measure the cardiac output. How? Because of the copper thermal filament, which could be embedded 30 centimeter proximal to the tip, so that it is approximately in the right ventricle. So this copper filament heats up the blood in the right ventricle, which is detected by the thermistor at the catheter tip. And the change in temperature over time is computed by the same equation. And the cardiac output is updated every 30 to 60 seconds, and an average value is displayed. And this is how the pulmonary artery catheter continuously monitors the cardiac output also using the copper thermal filament. What are the complications happen during insertion? Arrhythmias, right bundle branch block, complete heart block, catheter misplacement, knotting, vessel or valve rupture can happen during the insertion. Or there could be complications due to the catheter like infection, thromboembolism, pulmonary infarction, or pulmonary artery rupture. There could also be misinterpretation of the data, which is common for all cardiac output monitoring devices, like improper leveling, zeroing, improper location of the tip other than the zone 3, or overestimation, underestimation can happen. Overestimation can happen whenever you keep a higher PEEP more than 10 centimeters of water, whenever there is pulmonary arterial hypertension, or pulmonary veno-occlusive disease, or mitral stenosis, or mitral regurgitation, or tachycardia, or arrhythmias. In any of these situations, there could be overestimation of the cardiac output. Underestimation, if there is a diastolic dysfunction, or there is a aortic regurgitation, or pulmonary regurgitation, and right bundle branch block, or post pneumonectomy can all cause underestimation of the cardiac output. So this is with respect to pulmonary artery catheter. So basically, it uses a modified fixed principle where there is a cold saline injection, and the three such values are averaged based on the area under the curve using the Stewart-Hamilton equation. Cardiac output is derived. When I try to get evidences for pulmonary artery catheter with respect to cardiac output monitoring, it was not beneficial, but majorly the evidences were for what to say, in cardiac failure patients, how it is useful, in a critically ill patient, how it is useful. When you say Pacman trial or some of the trials with respect to heart failure registry, all were mostly with respect to hemodynamic monitoring in critically ill. But cardiac output monitoring specifically, there are no studies, but a few meta-analysis or the systematic review papers did not find it useful to be as a good cardiac output monitor because of various limitations as well as the invasiveness. And we can see nowadays, we rarely see pulmonary artery catheter in our ICUs, right? It usually is being used in the cardiac ICUs only. So the obsoleteness as well as the invasiveness and lot of limitations, all that makes the studies less validated. And there is no named clear-cut trials for pulmonary artery catheter with respect to cardiac output monitoring. Okay. Let us go to the minimally invasive devices. We saw that minimally invasive devices, either it follows a Doppler principle or a pulse wave analysis principle. And this pulse wave analysis principle is very important. It could come as a short note because this principle is being famous now because it is minimally invasive and all you need is what, an arterial line, a central line, and that's all. And you can easily measure cardiac output, right? So this minimally invasive devices follow three major principles. One is the transpulmonary thermodilution plus pulse wave analysis, or only pulse wave analysis, or pulse power analysis. We'll see individually. The first minimally invasive technique, which is commonly used by most of the named cardiac output devices, that is PICO, Volume View, LITCO Plus, is that transpulmonary thermodilution plus pressure contour analysis. And we already saw this device has to be externally calibrated to have a baseline value, and then the pulse contour analysis will continuously keep measuring the cardiac output. So you calibrate and then you continuously measure. You calibrate periodically and then the pulse wave analysis will continuously measure the cardiac output. That is how this device functions. Okay. So again, it uses a modified Stewart algorithm and a pulse wave analysis as its baseline mechanism. So you have to do a calibration intermittently. You have to inject a cold saline in the central venous catheter, where another arterial cannula is placed at the femoral axillary or brachial vessel, which has the thermistor, which detects this changes in the blood temperature. Okay, this is called transpulmonary thermodilution. The one which we saw with the pulmonary artery catheter is the pulmonary thermodilution, where you inject and the thermistor itself is sitting in the same circulation, which is detecting the changes in the blood temperature. But this is transpulmonary. You are giving it in the IJV and you are sensing it across the pulmonary circulation, and then you are checking it across the circulation through the heart and the systemic, and then you are sensing it in the different arterial cannula with a thermistor. That is why it is called transpulmonary thermodilution. So you can see that you inject the cold saline and then it reaches the peripheral arterial catheter, which senses the changes in the blood temperature. Okay, that is called transpulmonary thermodilution. And that is the method used for calibrating the device. And once calibrated, you are going to continuously measure the cardiac output using the pulse contour analysis. So what are the values we are going to get with transpulmonary thermodilution? Cardiac output, global end diastolic volume, intrathoracic blood volume, extravascular lung water, pulmonary vascular permeability index, cardiac function index, and global ejection fraction. So these are the major parameters which we are going to get from the transpulmonary thermodilution. And with pulse contour analysis, we'll be getting a continuous cardiac output monitoring with respect to pulse contour, that is with the stroke volume changes, and then stroke volume variation, pulse pressure variation, systemic vascular resistance, heart rate, BP, all that will be analyzed with the pulse contour analysis. So overall, this looks like a perfect device where you are getting a standard baseline value of cardiac output with a proper appropriate method, and then you are continuously monitoring using a simple method, and then you are getting most of the values out of it. So this looks like a perfect device for the cardiac output monitoring. So normally you have to keep the central line in the IJV and you have to insert the arterial line either in the femoral or in the brachial or in the radial like that. But if suppose a femoral vein is the site planned for the central venous access because of any reason where you cannot put the IJV, you have to put the venous access opposite to that of the axis of the arterial line, or else there will be a crosstalk phenomenon. Okay. And this pulse contour analysis uses a technique called area under the systolic portion of the arterial pressure waveform. As you can see here, it uses that technique to estimate the stroke volume, and it assumes that the changes in the arterial compliance over short periods are minimal. But the major limitation with pulse contour analysis is that the arterial compliance is not linear. It can change with age and it can vary between individuals. Okay. So we saw that the PICO system uses area under the systolic part of the pulse contour analysis, and it uses a technique called area under the curve, and also modified Stewart equation. Okay, so this is how the PICO or the volume view system looks. See, this is the sensor, this is the central venous catheter, and this is the thermistor. So you can see that a central venous line is inserted and a thermistor is there, which is going to detect the cold saline injection through the central venous catheter. And this is the arterial catheter, which has the actual volume view sensor system. Whenever there is a change in the temperature of the blood, it is going to sense it here and apply it to the auto-regulated formulas, and then it is going to display the values. And this is how the volume view monitor will look, where it detects most of the values using a lot of algorithms which has been formulated before. Again, PICO plus, there is a central venous catheter attached with a thermifold where you inject the cold saline, and this is being detected at the femoral arterial catheter, which has the sensor where it goes to the monitor, and then it calibrates, and then continuous pulse contour analysis measures the continuous cardiac output. Okay. So we saw that there are various parameters which are getting derived from this particular technique. One is the global end diastolic volume, which is the volume of all four cardiac active cavities at the end diastole, which is the index of the cardiac preload. The normal value is between 680 to 800 ml per meter square. So we can detect whether the patient is going to be preload responsive or not by using this global end diastolic volume, which could be a good predictor of preload. Okay. And it is also going to detect cardiac output by means of transpulmonary thermodilution as well as continuous pulse contour analysis. It is also going to derive a lot of indexes based on the body surface area of the patient. And it can also detect global ejection fraction, and the normal is between 25 to 35%. And it can also detect stroke volume pulse pressure variation because of the pulse contour analysis. And the two major important values which we are going to get from the PICO plus volume view is that it is the extravascular lung water index as well as pulmonary vascular permeability index. Okay. Extravascular lung volume is nothing but it is the volume of the pulmonary edema, that is water outside the pulmonary vasculature, right? The normal value, if you see the y-axis, this shows the extravascular lung water index. The normal value is less than 10. Okay. If the patient has any value more than 10, then we can think that cardiogenic pulmonary edema, that is the fluid outside the pulmonary vasculature, could be there could be a chance of cardiogenic pulmonary edema. If the value crosses 15 ml per kg, it indicates severe cardiogenic pulmonary edema. Coming on to the x-axis, the name itself indicates it is called pulmonary vascular permeability index, which actually says how permeable is the pulmonary vasculature, right? It indirectly tells us is there a risk of non-cardiogenic pulmonary edema is there or not. For example, in ARDS or any damage to the pulmonary vasculature because of TRALI, because of ARDS, because of any reasons. So whenever a patient has a value more than 2 to 3, there is a risk of non-cardiogenic pulmonary edema if the PVPI is more than 3. The normal value is between 1 to 2. So extravascular lung water helps us to detect about cardiogenic pulmonary edema, and pulmonary vascular permeability index helps to understand whether the permeability across the pulmonary vasculature, any non-cardiogenic causes are there for the pulmonary edema. So, what are the limitations with respect to TD, and pulse contour analysis? There could be aortic impedance and peripheral arterial resistance, which could hamper the cardiac output monitoring. There could be device related problems like bubbles, clots, or inadequate indicator fluid, or any valvular regurgitation, or aortic aneurysms, or arrhythmia, presence of the IABP, or if weight of the patient is less than 40 kg, or there is rapid change in temperature of the patient. All of this could be limitations to the cardiac output monitoring. And complications would be mostly catheter related, and vascular complications, like because of the insertion of the catheter, because all we are going to put is only a central line and arterial line. So what all catheter related complication, that is the most common one. So, what are all the errors that could happen with respect to PICO volume view? There could be indicator recirculation, meaning the amount of the cold injected that leaves the blood, enters the tissues, and again entering into the bloodstream. How much it is going to enter, we can't predict, right? It depends on how active is the tissue perfusion, and it enters back into the bloodstream. So, that indicator recirculation can happen. And indicator loss into the lungs because of pulmonary permeability or excessive volume in the pulmonary vasculature could happen. And errors due to respiratory variation, errors due to arrhythmias can happen. And presence of intracardiac shunt or intrapulmonary shunt can lead to varying cardiac output measurements. And any valvular regurgitation again will alter the blood volume and can cause alteration in the cardiac output monitoring, right? So we just saw a minimally invasive device that uses transpulmonary thermodilution and pulse contour analysis. That is PICO, volume view, and LITCO plus. Now, there is one small variation with respect to LITCO plus. We know that LITCO plus uses pulse power analysis rather than a pulse contour analysis, but the LITCO plus also intermittently calibrates its system using lithium rather than a cold saline, and that is why the name also. Okay. So, a beat to beat cardiac output monitor that calculates the stroke volume from the arterial pressure waveform using an auto correlation algorithm, which is called pulse power analysis. And it is going to calibrate its system by injection of the lithium, at least 0.5 to 2 ml boluses of lithium chloride through the central or a peripheral venous catheter. And there will be another arterial catheter which is going to sense this lithium using a sensor. That is how LITCO plus calibrates the system. Okay. See, with respect to LITCO means it is a lithium dilution technique. That is how the name originated. Okay. When LITCO plus came, which uses transpulmonary thermodilution plus pulse power analysis technique, that is LITCO plus. Okay. There are other newer versions of LITCO called LITCO Rapid, and there is also something called I don't remember the name, but LITCO Rapid. It is one of the uncalibrated system. But why it got its name? Because of the function of pulse power analysis, not because of the lithium dilution. So you have to remember, LITCO, among the LITCOs, LITCO plus is the one which uses lithium dilution as the intermittent calibrating technique, and it uses pulse power analysis to continuously monitor the cardiac output. Okay. So you can see that a bolus of lithium is flushed through the central or a peripheral venous line, and there is an arterial line which has a sensor which is going to detect the lithium, and this lithium washout curve is going to get formulated in the monitor, and using autocorrelation algorithm and the pulse power analysis, calibrated cardiac output as well as continuous cardiac output monitoring is going to happen. This is with respect to LITCO plus, and this is how a LITCO plus monitor will look like. Okay. And there is another version of LITCO, which is called LITCO Rapid. Though the name says LITCO, it doesn't use lithium dilution as a calibration. Actually, it is one of the uncalibrated devices. It mainly uses waveform morphology and pulse power analysis to detect the cardiac output. There is no lithium calibration with respect to LITCO Rapid. And this can be influenced by the vascular tone and the compliance, because we need to have an arterial line to see the pulse waveform. Whenever there is changes with the arterial compliance, there is going to be some changes in the cardiac output. Okay. I hope you understand. LITCO plus is the one which uses lithium dilution. LITCO Rapid, as the name suggests, it is one of the uncalibrated device, and all it needs is one single arterial line. Okay. Coming on to The next uncalibrated minimally invasive method is the flow track Vigilio. Actually, flow track is the sensor which is going to sense the pulse waves, and Vigilio is the monitor which is going to show us the values. So flow track Vigilio comes as one of the same hemodynamic system. Both are not different. Okay. So pulse pressure analysis is the method which is used in flow track or Vigilio, where arterial pressure based cardiac output monitoring technology, which estimates the stroke volume and the cardiac output using arterial waveform analysis. So there is no need to externally calibrate. It automatically calibrates based on the nomogram based approach. For example, patient's age, demographics, as well as the arterial compliance of the patient. Okay. So as I told you, there is a mechanism called pulse pressure analysis, where the system samples the arterial pressure waveform at 100 Hertz over 20-second intervals, generating 2000 data points. And that will be reflected in the Vigilio monitor as various cardiac output values. Okay. Advantages, it is minimally invasive. Number one, all you need is an arterial catheter. There is no need of central venous catheter. There is no need to manually calibrate the device. It is internally calibrated. It can even be used in patients who are having arrhythmia and spontaneous breathing efforts, which could induce a lot of hemodynamic changes because of the HLI. And it gives us a continuous cardiac output monitoring with a single arterial line. These are all the advantages of flow track. What are all the disadvantages? Whenever there are extreme conditions like very severe septic shock or high dose of vasopressors, or the patient is having extreme distributary shock, then in such cases, the cardiac output monitoring may not be appropriate. And it could be affected by the arterial waveform damping, like whatever things that could happen with the invasive BP monitoring, those mechanical challenges are there with flow track also. And it can be less reliable in patients with aortic regurgitation and shock states. Okay. The next calibrated method, one of the internally calibrated method is called PRAM, which is also called pressure recording analytical method, where it measures the signal at a frequency of 1000 samples per second. After assessing the signal, it is going to give us various waveform patterns, which may indicate various conditions on the patient and also the hemodynamic monitoring. I mean, I have not seen PRAM. It is based on the literature as well as the review articles. So coming on to the next minimally invasive device, which is transesophageal echo. So by the name suggests, we have to do an esophageal echo, a minimally invasive one, where the ultrasound waves are going to play a major role to visualize the cardiac structures, and also a Doppler is going to sense the blood flow velocity. So this is a common understanding, right? So it is going to measure the stroke volume by calculating the velocity time integral of the blood flow across the left ventricular outflow tract. A Doppler is going to measure the blood flow velocity, and you are also going to get the left ventricular outflow tract cross-sectional areas. So basically, cardiac output is equal to stroke volume into heart rate. We know this formula. And here, using an esophageal echo, the stroke volume is going to get calculated by a velocity time integral at the left ventricular outflow tract into cross-sectional area of the left ventricular outflow tract. Cross-sectional area is going to get calculated by this formula, and VTA is by means of Doppler principle. Okay? So you can see that at the lower end of the esophagus, you're going to place the probe, and the ultrasonic waves is going to detect the blood flow across the descending aorta. And then it is going to give a velocity time integral curve, and area under the curve gives us the value of the velocity time integral. And by normal echo imaging, we can easily get the left ventricular outflow tract cross-sectional area. Multiplying these two will give us stroke volume, and multiplying with the heart rate of the patient is going to give us cardiac output. Okay. So as I told you, a Doppler probe, we are going to insert it into the distal esophagus, and it is directed to measure the blood flow in the descending aorta at about 35 to 40 centimeters from the incisors. And the monitor calculates the cardiac output using the descending aorta diameter, which can be obtained from age-related nomogram or measured directly in the newer machines. There are going to be various factors which is going to give us clue about preload, afterload, which we'll be discussing in the next slide. The only problem with the transesophageal echo is that there are various assumptions when we do a transesophageal echo. These assumptions may not be universally possible in all critical ill patient or in all cardiac patients, right? So what are all the assumptions the transesophageal echo makes? Number one, it presumes that the Doppler can precisely measure the blood flow velocity in the descending aorta. And it also presumes that all the red blood cells move at the same speed throughout the vessels. Okay. And it also presumes that based on the age related nomograms, the cross sectional area is going to be the same as per the age factor. Okay. And it also ignores the diastolic flow. Okay. And it also believes that only 70%, the majority 70% of the blood flow is going to happen in the descending aorta, and only 30% is going to happen with the aortic arch. So you have to add a correction factor, which may not be universally true in all the patients. Okay. So it is going to assume various things to do the transesophageal echo and calculate the cardiac output, which could be a major limitation during cardiac output monitoring. I'll just repeat the assumptions. It believes that the blood flow velocity in the descending aorta can be sensed by the Doppler, and it also believes that all red blood cells move at the same speed, and it age related cross sectional area will be appropriate as per its nomogram, and it totally ignores the diastolic flow, and it believes that a fixed 70% only goes into the descending aorta and 30% in the aortic arch in the upper part of the aorta. And it also believes that the beam alignment, the blood flow movement, all that is appropriate, but which may not be possible. It could vary with the operator who is doing the procedure, or any vascular like arteriosclerosis, or there is stenosis, or there is changes with the cardiac function. It could vary. These assumptions may not even hold true in all patients. What are all the parameters we are going to measure from the transesophageal echo? Number one is the cardiac output, which we already discussed, stroke volume into heart rate. You're going to assess the stroke volume using the VTI as well as the left ventricular outflow tract cross-sectional area, and you're going to multiply it with the heart rate. That is the first parameter. It can also detect the stroke volume, which we discussed with the formula. And it also measures something called corrected systolic flow time, that is FTC, which indicates the preload of the patient. And the normal value is between 0.33 to 0.36. And it also measures a value called peak velocity, where you can see the amplitude of the wave, which you are getting from the Doppler principle, the peak velocity, which actually indicates contractility of the patient. And the normal range is mostly age related. In younger age, the values are more, between 90 to 120 centimeters per second. In older age, it is between 30 to 60 centimeters per second. So when we see the FTC and the peak velocity, it gives us a clue about preload, afterload, and the contractility. Okay. So as I told you, the height of the curve, because of the Doppler principle, which we get, that is the blood flow velocity in the descending aorta, which we get, is called the peak velocity. The highest detectable aortic flow, which could be a measure of afterload, vascular resistance, and contractility. Okay. And the slope of the upstrake, which is called mean acceleration, which could be a measure of contractility. And the width of the base, which is the flow time, and there is also a corrected flow time, which is nothing but left ventricular ejection time, that is duration of the aortic blood flow. When corrected, it could give the index of preload. And area under the curve, which is the stroke distance, can give us the VTI. And the stroke distance can give us the aortic cross-sectional area. And these factors could also detect the systemic vascular resistance or the afterload. So what are the advantages? Of course, it is minimally invasive. Only minimal training is required. And there is minimal interference from the thorax, bone, lung, soft tissue, which could be a major factor with respect to transthoracic echo. It can be quickly inserted and analyzed. And the system is small and relatively portable, and even pediatric probes are available. But what are the disadvantages? May require sedation, and you need a proper operator who could fulfill all the assumptions which are made during the transesophageal echo. And if we are using diathermy, it could interfere with the measurements, and appropriate probe positioning is very important. And if there are any shunts or there is problem with the pulmonary or the cardiac shunts, then possibility of wrong values are there. And if there are esophageal varices, then this procedure is not indicated. So these are some of the disadvantages of transesophageal echo. So as I told you, it has a lot of assumptions. So what all could be the limitations? The limitations will be most of the assumptions which I told you, and it presumes that the flow in the descending aorta contains 70% of the total blood flow. So it is necessary to add a correction factor to compensate the blood flow on the aortic arch. And in cases of aortic coarctation, aortic aneurysm, in the presence of IABP and various metabolic conditions, there could be various flows which could affect the assumptions as well as the overall cardiac output monitoring. And it could also be affected by changes in the pulse pressure, vascular compliances, and volume status, and the presence of the inotropes. Okay, these could be the limitations of transesophageal echo. So we have seen a fully invasive method, that is a pulmonary artery catheter, which uses pulmonary thermodilution technique, a modified fixed principle to detect the cardiac output. We saw a minimally invasive techniques, which uses majority pulse wave analysis with transpulmonary thermodilution and with flow track Vigilio and PRAM. These are some of the techniques with respect to pulse wave analysis. And one is the transesophageal echo. So we have seen the minimally invasive techniques. We are going to see non-invasive methods. So the first non-invasive method which we can use is the transthoracic echo. If the window is good, we will be able to definitely find out the left ventricular outflow tract area, where it uses the same formula as an esophageal echo. You have to go to the parasternal long axis view, and you can get into the left ventricular outflow tract. Just below the outflow tract, you measure the diameter in centimeter, and you can apply it in the formula to get the left LVOT area. And again, same as esophageal echo, you can find here the left ventricular outflow tract velocity time integral, where you have to get a 5-chamber view, and you place your marker at the aortic valve, okay, and put a pulse wave Doppler. You will immediately get a velocity time integral curve, where area under the curve will be calculated and VTI will be measured. It will be automatically reflected in the screen. So using these two, you can find out the stroke volume, and then you multiply it with heart rate, you get the cardiac output. But this may be possible only if the windows are good and the operator who are doing it should be more experienced and trained. Okay. The next non-invasive method is the bioimpedance. So bioimpedance and bioreactance, these are electrode-based methods where you are actually pasting some of the electrodes across the neck and across the chest, and you are seeing the electrical voltage or the impedance of the electric current because of the blood flow across the thorax. Okay, this is the simple definition of the bioimpedance and reactance techniques. So bioimpedance, it mainly assesses the resistance to the current flowing from the outermost to the innermost electrodes. And this bioimpedance is indirectly proportional to the content of the thoracic fluid. So the tissue fluid volume, the pulmonary and the venous blood flow, and the aortic blood volume all contribute to the bioimpedance measurements. So you're going to keep 6 electrodes. 2 are placed on the either side of the neck, and 2 are placed on the across the chest in the lower thorax. Okay, and changes in cardiac output is basically with the help of the formula, where it detects the resistance to the current flowing across the chest from one electrode to other electrode, mainly because of the blood flow volumes and the electrical current conduction across the blood flow volumes. Okay, it mainly measures the resistance. So you can see here there is a formula for stroke volume calculation, where it is equal to volume of the electrically participating tissue, that is the blood volume, the fluid volume, all the participating tissue, and the volume, the ventricular ejection time taken from the RR interval using the ECG, and the ejection phase contractility index, using which we can find out the stroke volume. What all could be the limitations? If there is any other electrical, like because of the electrocautery or diathermy, it can interfere with the measurement, and inappropriate positioning of the electrode can impede the measurement. Patient movements, obesity because of the heavy chest wall, or presence of pleural effusion, where even that fluid will be taken into cardiac output calculation, and arrhythmia, Again, there is an electrical interference to disturb the cardiac output monitoring. Any sternal wires or could all like interfere with the measurement of the bioimpedance. Okay. Coming on to bioreactance. So bioimpedance basically measures how much is the electrical resistance changes when the heart pumps blood. Okay. But bioreactance, it measures the electrical voltage signal to the current applied across the thorax. There, that measures resistance. This measures electrical voltage signal changes. Okay. So it is a modification of the bioimpedance where the interference by the noise or the external sources could be avoided. Okay. Changes in the electrical capacitive and inductive properties occur secondary to the changes in the intrathoracic volume. It can be useful in patients who are intubated, who even have arrhythmias, who can be in the emergency room. There won't be any noise interferences because it mainly uses voltages rather than resistance to the electricity. And it can be used in the ICU operating room also. So you can see that how much is the electrical resistance is measured by the bioimpedance, and how the timing electrical signals changes is measured by the bioreactance. Then coming on to the next non-invasive method, of course, endotracheal tube is invasive, but if the patient is already on it, then it is non-invasive. So it is basically a plethysmography of the impedance, which is being measured in the endotracheal cardiac output monitoring device, where there is a source electrode. Okay, the electrical current passes through the source electrode on the body of the endotracheal tube. And the change in the impedance in the aortic blood flow, which is in contact with the lower part of the tube, is being detected by the electrode on the cuff. So stroke volume and the cardiac output can be calculated based on the algorithms which are already created based on the impedance changes. So that is how the ECOM device performs. Coming on to the next non-invasive device, that is photoelectric plethysmography. Basically, you apply a cuff around the finger and the pressure changes across the finger cuff vessels, the finger vessels, shows us one of the waveform from which algorithm is formed and cardiac output is being detected. So it measures the pulse pressure using the photoelectric plasticization combined with volume clamp technique, that is the flexible finger cuff. The cuff maintains a constant blood flow in the arteries, okay? And the pressure required for this operation is proportional to the arterial pressure curve. You can see that. So there is a pressure applied to the finger vessels, and using which the proportional blood pressure waveform is being constructed. So after analyzing these pressures, blood pressure is calculated by the algorithm of the device, and the cardiac output is obtained from this pressure curve by means of pulse contour method. Okay. In cases of low cardiac output state where the patient is having cyanosis or peripheral discoloration or decreased perfusion, this may not be possible. Okay. Coming on to pulse wave transit time analysis. This is one of the non-invasive device where it is also called SCCO, where you can see that a probe, a single SpO2 probe can detect the cardiac output in the patient. So how it is deriving the cardiac output? It is mainly based on the principle of inverse correlation between stroke volume and the pulse wave transit time. So that it is defined as the time from the electrocardiogram, that is R wave peak, to the pulse wave rise point, which is defined as the point where the differentiated pulse wave reaches 30% of its peak amplitude. It will be more understanding in the next slide. Okay. So it is acquired from the delay of the pulse oximetry waveform and the ECG R wave signals of each cardiac cycle. Basically, it uses the pulse oximetry waveform and the R wave of the ECG. That is in gist. Okay. And it uses this formula to calculate the cardiac output. So the pulse wave transit time. So you can see here in the formula, you need the pulse wave transit time. That is being assessed by 3 different periods. One is the pre-ejection period, where it is from the time of the ECG, where R wave rise to a point, to the point of the aortic root pressure wave. And there is a second phase where it is called a pulse wave transit time through the elastic artery, that is T1, the time from the rise point of the aortic pressure wave to the rise point of the radial artery pressure wave. And then comes T2, which is the rise point from the radial artery pressure wave to the rise point of the pulse oximetry wave measured by the SpO2 probe on the fingertip. Basically, it measures the from the R wave in response to the aortic pressure wave, in response to the arterial pressure wave, and in response to the pulse oximetry pressure waveform. So with this algorithm, it calculates the pulse wave transit time from the R wave to the pulse oximetry waveform, and it applies on the formula and detects the cardiac output. Genuinely, when I read it, I didn't understand much, but I tried to make it as simple as possible because we don't see this in a day-to-day practice. Definitely, it is very difficult to understand. But just remember to write if suppose non-invasive techniques are asked, then you will remember only bioimpedance, bioreactance, only these two. But if you have to get good marks, even 5 out of 5, I'm telling, you have to mention the other techniques also. So you have to at least mention the endotracheal tube, the pulse wave transit time, which all are being used in some of the international operation theaters and the ICUs. Then coming on to the modified fixed principle, I think this should be easy to understand, where we have a fixed principle. We used oxygen to calculate the fixed principle cardiac output. That was an invasive one where you put in a line, you take samples, and then you see how the oxygen goes and you're measuring the cardiac output. Where here in modified fixed principle, you are going to use carbon dioxide in place of oxygen. The formula remains the same. BtCO2 the blood flow, the content of the carbon dioxide in the lung is equal to the product of the blood flow and the arteriovenous difference. The principle remains the same, but we are going to apply it in the carbon dioxide. Okay. So first, the patient is ventilated where there is an EtCO2 monitoring. And whenever the patient expires, whatever EtCO2 monitoring happens, it is the VCO2. And when you connect a rebreathing technique, when you connect a rebreather circuit, the patient is going to rebreathe the carbon dioxide which is expiring, and the carbon dioxide level in the lung as well as in the blood is going to come to a level of mixed venous oxygen saturation. So we are going to get the CVCO2. So we already have VCO2 from the EtCO2. We already have a mixed venous saturation by means of the rebreathing technique, that is CVCO2. And you draw ABG where you have an arterial carbon dioxide. So you have all the three values and you're going to apply it and look for the cardiac output. This is the modified fixed principle. Okay. But the limitations are the need to place the chip with the ventilator constant settings, because not all the patients rebreathing can be allowed, which may be life threatening. And it may not be reliable in patients with severe chest trauma or intraperitoneal shunts or high cardiac output status or low ventilation. Okay. So this is the overall gist of the cardiac output monitoring. Initially, we saw the most invasive technique, but the gold standard technique, the fixed principle and the pulmonary artery catheter. As I told you, there are no major validation studies specifically for the cardiac output monitoring, but whichever trials has been released for any other hemodynamic monitoring has not proven so beneficial. It is mainly because of the invasiveness, the cumbersome techniques, and multiple hemodynamic variations that could happen with the catheter. Okay. And then we saw the minimally invasive techniques where it needs only a central line and the arterial line to detect the transpulmonary thermodilution and the pulse wave analysis, like PICO, Volume View, or LITCO Plus, where these devices are well validated with trials. And the only disadvantage may be the device related, catheter related complications, or if the patient is having a valvular issue, and the need for recalibration could be some of the cumbersome issues. Okay. Then we saw other minimally invasive device as the transesophageal echo, where again it is easy to do, but you need a trained professional to do that. And secondly, most of the assumptions could be limitations in such cases. Okay. And finally, we saw the non-invasive techniques where bioimpedance and bioreactance are validated in some of the studies, but bioreactance has been proven more beneficial than the impedance because it avoids most of the interferences, because it detects the electrical voltage rather than the resistance of the electric current. So bioreactance has been validated in most of the studies. Okay. So this completes our cardiac output lecture. I have included most of the methods as much as possible as a gist. Any part can be asked as a 5 mark or a 10 mark, and every question paper always had a cardiac output monitoring device. Just please make sure you're at least mentioning the topic, the technique, and how they are doing it, and how what are all the major limitations and complications. This 4 topics, 4 to 5 topics should be there in your paper to get the full score. Okay. I'm sorry if I was a bit fast because there were 67 slides. I tried to explain. If there is any doubt, you can put it in the WhatsApp or personally message me. I will share the articles or even share the voice note to explain you again. Okay. If it is okay, we can finish the infective endocarditis now, because Dr. Sananta's class is going to be a bit extended lecture tomorrow. Is it okay? Shall we proceed? Can any one of you respond back? Or even if you couldn't attend, you can see the recorded classes. That is also possible. Is it okay to proceed? Okay, like as we have time, it is we'll just finish off the infective endocarditis as there is no response from you people also. So Bhagishri, is it okay to continue the recording?
Yes, ma'am, you can record.
So the third topic we are going to see for today is infective endocarditis. It is a very small topic. When we saw the previous year question papers, not many questions came from infective endocarditis, but definitely, yes, the criteria and the need for the anticoagulation, the need for the surgery in infective endocarditis has been some of the sub questions in 5 mark questions or 3 mark questions. So in that way, at least if you write all the points, you may score full in with respect to infective endocarditis. So what is infective endocarditis? It is a life-threatening infection of the endothelial lining of the heart, usually the heart walls, or it could be a mural thrombi also, or it could be an endothelial surface on which the jet stream from a stenotic lesion pours on or impinges. Okay. So it could be either the heart wall or the mural thrombi, or it could be the endothelial surface which could lodge the thrombus or the infection. What is infective endarteritis? It is the infection of the endothelial surface of any blood vessel, like a previously damaged vessel, for example, in cases of aneurysms or the vessels which have been manipulated externally with because of fistulas or grafts. These are some of the potential sites where you could have a thrombus as well as a secondary bacterial colonization. So this is called infective endarteritis, which could similarly manifest as in case of endocarditis, because ultimately it is the emboli, septic emboli, which is passing on to various organ systems, right? So what are the risk factors for infective endocarditis? Number one is the cardiac factor, where the patient can have, if the patient has a bicuspid aortic valve or a mitral valve prolapse, or if the patient is having a rheumatic valve disease, or if the patient is having congenital heart disease, or prior infective endocarditis, or patients with implanted cardiac devices like permanent pacemakers or ICDs, or prosthetic heart valves. These are some of the commonest cardiac risk factors for infective endocarditis for the bacteria and the thrombus to lodge. And some of the comorbidities which could be risk factors are intravenous drug use, CKD, CLD, malignancy, advanced age, corticosteroid use, poorly controlled diabetes, indwelling catheters, and immunocompromised state. These are some of the comorbidities which could be the risk factors for infective endocarditis. This is one way of classifying infective endocarditis based on the duration. Acute infective endocarditis is one where the clinical manifestations are seen less than 2 weeks, where patient can have fulminant infection, abrupt onset of fever, leukocytosis, systemic toxicity, complicated heart failure, septic shock, and possibly death. But subacute ones are the ones which happens over more than 2 weeks, where it is insidious in onset and non-specific symptoms spanning for weeks to months. And the other way of classifying is that based on the presence of underlying cardiac risk factors. For example, it could be native valve endocarditis, it could be prosthetic valve endocarditis. And in prosthetic valve, we have yearly, if it is less than 12 months following surgery, and late more than 12 months following surgery, or patients who inject drugs called infective endocarditis because of the peripheral injection of the drugs. Or it could be nosocomial infective endocarditis if the infective endocarditis happen more than 72 hours after admission to the hospital, or acquisition of the infective endocarditis in association with an invasive procedure performed during the recent hospitalization less than 8 weeks before the onset of symptom. That is called nosocomial infective endocarditis, or infective endocarditis related to the intravascular foreign bodies like vascular catheters or pacemakers. Coming on to organisms, the most common organisms are is staphylococci. 30 to 70% of the cases because of staphylococci. Coagulase positive is around 20 to 68%. Coagulase negative is around 3 to 26%. Streptococci, viridin streptococci is around 10 to 28%, and other streptococci is around 3 to 14%. And enterococci also has a significant incidence of 5 to 18%, and gram-negative bacteria between 1.5 to 13%. Fungus is even rare, 1 to 9%. And miscellaneous bacteria like Hague group of organisms, Neisseria, Pseudomonas, Legionella, Lactobacilli could be seen in less than 5% of the cases. And culture negative can also be seen in approximately between 5 to 17% of the cases. But all you have to remember is Staphylococcus and Streptococcus are the most common. So whenever you are starting the antibiotic also, your antibacteria should cover this antibiogram with the most common organism. Okay. Coming on to pathophysiology of the infective endocarditis, you can see that there is normal endothelium. Whenever there is a bacteria, it is resistant to the pathogen because of the underlying immune factors. But infective endocarditis begins with the bacterial adhesion to the tissues, with the circulatory system, especially the vascular endothelium or the endocardium or any valvular apparatus sitting there. Once the bacteria adheres to the endothelium, there is stimulation of the inflammatory response, and cell-mediated, chemokine-mediated, cytokine-mediated factors enter into, like integrins, tissue factors, adhesion molecules, all play a role, and they attract the monocytes and the platelets with the associated production of fibronectin, which leads to thrombus formation. So once the thrombus forms, it starts embolization into various organ systems. And diagnosis is mainly based on clinical echocardiography and the microbiological evidence of infective endocarditis. And laboratory markers also play a role, but this has been fit into the minor criteria. And vascular immunological phenomenon also play a role. So what are the clinical features of infective endocarditis could be? Patient can have malaise, clubbing, murmurs and presentation with cardiac failure, arthralgia, pyrexia, and some of the skin lesions like osseous nodes, splinter hemorrhages, Janeway lesions, petechiae could be seen. And in the eye, there could be rod spots or conjunctival splinter hemorrhages. And there could be splenomegaly because of the emboli and back pressure. And neurological, there could be cerebral emboli and mycotic aneurysm. And renal, there could be hematuria. So infective endocarditis is associated with wide variety of complications, including cardiac, where the patient can have congestive heart failure, valvular dysfunctions, arrhythmias, myocardial abscess, and myocardial infarction, which could be some of the complications could be indication for immediate surgery. In the brain, there could be stroke, abscess formation, intracranial hemorrhage, intracerebral abscess, meningitis, and infective intracranial aneurysms, which could rupture. In the eye, as we discussed, there could be rod spots. In the kidney, there could be acute kidney injury, glomerulonephritis, and infarction. In the musculoskeletal system, there could be osteomyelitis and arthralgias. In the skin, there could be Janeway lesions and osseous nodes. And as per the embolic complication, it can go into the spleen, lung, kidney, liver, and cause various complications. And patient can also have a metastatic infection because of the embolic complications. So this is the recent 2023 Duke's criteria, where the major criteria includes, as we discussed already, there should be clinical, microbiological, as well as imaging criteria to prove there is a infective endocarditis. First is the major criteria, microbiology criteria, where the patient should have 2 or more positive separate sets of blood cultures for organisms typical of endocarditis, or 3 or more positive separate sets of blood cultures for organisms that rarely or occasionally cause endocarditis. This is one of the microbiological criteria. Or the patient should have PCR or other nucleic acid technique that identifies Coxiella burnetii, Bartonella, or Trophirima whipple from blood, or serological evidence of Coxiella burnetii, where the titer should be more than 1:800, or one positive blood culture of Coxiella burnetii should be there as a atypical organisms for infective endocarditis. Coming on to imaging evidence of infective endocarditis that fits into the major criteria, that is echocardiography or a cardiac CT showing vegetation, valvular or leaflet perforation, aneurysm, abscess, pseudoaneurysm, intracardiac fistula, or an echocardiography showing a new valvular regurgitation or worsening or changing of pre-existing regurgitation, or there is new partial dehiscence of prosthetic valve. All could be major echocardiographic evidence. And the second imaging evidence could be FTG PET CT imaging with abnormal metabolic activity involving a native or a plastic valve, or an ascending aortic graft, or an intracardiac device leads, or other prosthetic material. So either you can use echo or a cardiac CT, or you can use the PET CT, FTG PET CT, to see the metabolic activity for an evidence of infective endocarditis. Okay. And number 3, surgical evidence. You directly go open the valve during the surgery. You can observe the various vegetations and the emboli sitting there. That is another surgical major criteria. So it could be there should be microbiology, imaging, or even if surgery shows, then it proves infective endocarditis. And what are all the minor criteria? Predisposition. For example, previous history of infective endocarditis is there. There is prosthetic valve. There is previous valve repair, congenital heart disease, or any regurgitation or stenosis of the valves, endovascular implantable devices, or hypertrophic cardiomyopathy, or injection drug use, or presence of fever more than 38-degree persistent fever. These all could be predisposing factors or of the minor criteria. Then coming on to the vascular phenomenon, like arterial embolism, septic pulmonary infarction, abscess of the cerebrum or the spleen, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, Janeway lesions, purulent purpura, or some of the vascular phenomenon that fits into the minor criteria. Or it could be immunological phenomenon like glomerulonephritis, osler nodes, rod spots, or presence of rheumatoid factor, are some of the minor criteria. And minor criteria microbiological evidence should be blood culture showing an organism consistent with infective endocarditis, or positive PCR culture of the atypical organisms, which could be detected by the PCR or any other nucleic acid amplification test. These are some of the minor criteria. And along with that, imaging minor criteria is that PET CT detecting a metabolic activity in the prosthetic valves, or any other intracardiac devices, or if the echocardiography is not available, even auscultatory evidence of new valvular regurgitation can be fit into minor criteria. Coming on to echocardiography. So there is always a confusion whether transthoracic echo should be done first when there is a suspicion, or a transesophageal echo should be done whenever a suspicion of infective endocarditis. But as per AHA as well as the European guidelines, when you are very definite it is infective endocarditis, you consider a cardiac CT or a FDG CT, PET CT for the picking up of the metabolic activity or the complications of the infective endocarditis. But when you're not sure, you can use a first transthoracic echo. If not, then followed by the transesophageal echo. And then once it is a possible infective endocarditis, you can go ahead with the other CT imaging to rule out the complications as well as to confirm the definitive diagnosis of infective endocarditis. Okay. And in some cases, repeat transesophageal echo, even if the transthoracic echo should be done if the patient is having persistent symptoms of endocarditis after 7 to 10 days with respect to European guidelines, or after 3 to 5 days with respect to American guidelines. And there are other diagnostic options in cases of blood culture negative infective endocarditis. One is the PCR, we already saw, any nucleic acid amplification techniques, or histopathology from the surgery, or serology can be done to detect the antibodies, or immunohistology or autoimmunohistochemistry can be done for specifically Bartonella and Bernete species. And genomic analysis can also be done in cases of culture negative infective endocarditis, which is very rarely done. Coming on to the management, as I already told you, the first line of management is the antibiotic, and you have to cover the most common organisms. That is, the Streptococcus, Staphylococcus forms the majority, right? So that both should be covered with your antimicrobial therapy. So the initial empirical therapy can be started with any one of the antibiotics like ampicillin, cloxacillin, ceftriaxone, or vancomycin, but you have to include gentamicin also until the pathogen is identified. But based on the blood culture, if it is a streptococci, if it is a native valve, then you start ceftriaxone plus gentamicin, which has to be continued for 4 weeks. If it is a prosthetic valve, again ceftriaxone plus gentamicin for 6 weeks. If it is a staphylococci, then in a native valve endocarditis, you can start flucloxacillin or cefazolin or vancomycin based on the sensitivity. You have to continue for 4 to 6 weeks. If it is a prosthetic valve, then you have to add along with gentamicin and rifampicin and continue for 6 weeks. If it is enterococci in a native valve, then you have to give ampicillin plus gentamicin, or vancomycin plus gentamicin, or ampicillin plus ceftriaxone for 6 weeks. If it is a prosthetic valve, then again same combination only for 6 weeks. If it is a culture negative native valve or a prosthetic valve, based on the epidemiological factors and the infectious disease specialist expertise, we have to change the antibiotic. Once the patient has received 4 to 6 weeks of antimicrobial therapy, if suppose you're discharging the patient from the ICU, you can switch the patients to oral therapy. In cases of streptococci which are penicillin sensitive, you can add amox alone for native, amox plus rifampin for prosthetic, and linezolid, moxifloxacin with rifampin can be tried. In case of penicillin intermediate streptococci, you can try amoxi with rifampin, linezolid with rifampin, moxifloxacin with rifampin can be given. In case of Staphylococcus species, you can add levoflox with rifampin, linezolid plus rifampin, or Septran alone in divided doses. Okay. Coming on to prophylaxis in cases of infectious endocarditis, usually it is done before the dental procedures or before the vaginal delivery. Okay, so dental procedure involves manipulation of the gingival tissue or periapical region of the teeth or perforation of the oral mucosa. As per the American as well as European guidelines, if the patient is on prosthetic valve, if the patient has a previous history of infective endocarditis or any congenital heart disease or structural heart disease, you have to definitely give the prophylactic therapy. And in cases of vaginal delivery, if the patient has a past history of infective endocarditis or structural congenital heart diseases or any prosthetic cardiac devices are there, then you have to give before the vaginal delivery. And surgical intervention. So when we compare both the European and the American guidelines, surgical intervention of the infective endocarditis has to be done in cases of patients presenting with heart failure with severe valve dysfunction and LV dysfunction, or in cases of uncontrolled infections where despite antibiotics, the patient is having embolic phenomenon or persistent infection, abscess, local complications, fistula, or resistant organism. Or there is a large big vegetations which could be detected even in the transthoracic echo, which has the risk of getting embolized to the brain or any other smaller circulation. Then you have to definitely subject the patient for surgical intervention. But with respect to American and European guidelines, there are some differences when it comes to surgical intervention. European guidelines defines the timing of the surgery as emergent, urgent, and elective. Emergent will be immediate, urgent will be less than 24 hours, and elective will be like within a week time. Whereas American defines it as an early surgery. That's all. And European guidelines says whenever the vegetation crosses the size of more than 30 millimeter, that is when the patient will be subjected to surgery. But American says if the patient has a vegetation of more than 10 millimeter, then we have to subject them to surgery. And if there is a embolic phenomenon with 10 vegetation, then you have to subject to surgery in case of European. With no or embolic phenomenon plus 10 vegetation, then you have to subject to surgery according to American conclusions. So overall, this surgical decision will be decided by the CTVS surgeon based on any one of the guidelines, but it's mainly based on clinical situation of the patient, where without surgery, there could be high mortality in patients presenting with large emboli, with a septic embolic phenomenon and a severe heart failure with local complications. So, indication for surgical management with respect to right-sided infective endocarditis are heart failure with severe tricuspid regurgitation, or there is a presence of atrial septal defect, or there is a persistent culture positivity even after 7 days of antibiotic, and there are other resistant microorganisms like fungal or MDR organisms. Or with an autoimmune phenomenon coexistence. And if suppose there are vegetations on the tricuspid valve more than 20 which persist even after recurrent pulmonary embolism, in such cases, you have to subject the patient for surgical management. When it comes to left side of the heart infective endocarditis, if the patient has heart failure with valvular regurgitation, shunt physiology, shock, pulmonary edema, then you have to subject them for heart surgery. And uncontrolled infection despite of 7 days of antibiotics and other resistant microorganisms like VRE, MRSA, then you have to subject them for at least within 2 weeks of the presentation to the surgery. And if the vegetations are more than 10 or 15 with associated valve stenosis or regurgitation, then you have to subject them to surgery in case of left-sided infective endocarditis. When should we give antithrombotics? Let it be antiplatelet or anticoagulation. There is no definite guideline based with respect to American or European, but there was a meta-analysis in 2024 which says that in patients with infective endocarditis, patients who were on anticoagulation, the risk of hospital mortality was less, systemic thromboembolism was less, but with respect to cerebrovascular events or intracranial hemorrhage, there was no major difference. Okay, so when you're deciding on the antithrombotics, seeing the patient profile and individualizing the protocol based on the patient profile will help rather than like having a universal fixed protocol for anticoagulation. Okay. So this completes our topic for infective endocarditis. If there is any doubt with respect to cardiac output monitoring or the heart-lung interaction, please get back to me. This will be the end of our cardiac chapters. Tomorrow, Dr. Sananta will be covering. Okay.